So we're going to get started for this evening with part 3 of this web series. We can do hard things in Huntington's disease together, late stage Huntington's disease. Today, we will cover the following topics. I will quickly overview just a few bits from part 1 and 2 of this series. We will delve into some kinds of advanced symptoms that can be seen in late-stage Huntington's disease. The 4 of them will be caregiver strain, changes in communication, alternative feeding options, and coping with disease progression. Even though these were the 4 that we ultimately chose to highlight tonight, I want to say that there are many, many that we probably could never fit into a 1-hour talk. These were the ones that we felt like when you take them into consideration with the other symptoms that we have addressed throughout these web series would be important to talk about tonight, but they are certainly not comprehensive. We will then talk about transitioning to hospice and provide an important overview of hospice with an emphasis on how different it may be or how similar it might be to palliative care. In our overview of part 1, I'd just like to review a few definitions. Palliative care is a medical specialty that focuses on quality of life. Palliative care uses a team approach to highlight the many aspects of life that can be affected by a serious illness. You can see the team members that typically can be part of the palliative care team on your right. They include the medical team, the doctor and the nurse. They include the palliative social worker who provides emotional support or helps connect people to resources, and the palliative chaplain who provides spiritual and existential support. Palliative care is available to all people living with a serious illness at any age and at any stage. So I always like to emphasize this point, especially because as we go on to talk about hospice, that will be an important distinction between the two. Again, there's no prognosis that is necessary for you to access palliative care. Palliative care includes, though is not limited to, hospice care. So often we like to think of palliative care as a big, broad umbrella of a medical specialty that focuses on quality of life. And hospice care is an even more specialized type of care for people who are reaching the end of life. And it falls under that big, broad umbrella of palliative care. I put this image up just to kind of summarize the overall themes that we covered in part 2. Palliative care likes to take a holistic approach to someone's care, and that includes managing any kinds of symptoms. While we know that certainly people can experience physical symptoms, we know that more than body can suffer. So certainly people can experience emotional and psychological effects of their symptoms, as well as kind of the practical aspects of life being affected by different symptoms. The finances or navigating the healthcare system can all contribute to your experience of illness and Huntington's disease. And of course, the spirit itself, our sense of meaning and purpose and where we exist in the universe can also be deeply influenced by our experience of illness as well. And therefore, because our experience of symptoms and illness can be holistic, palliative care tries to take that team-based approach to address all the aspects of life that can be affected by illness. Some of the symptoms that we covered in part 2, if you wanted to rewind to review them, included changes in swallowing, changes in bowel function, pain, having more falls, and more. I've actually placed here the 2 QR codes that you can scan. If you're watching the recording and want to get back to part 1, which was early stage Huntington's disease, you can pause now and scan the QR code on the left. If you are watching the recording and want to pause and watch part 2, mid-stage Huntington's disease, you can scan the QR code on the right. And after we are able to complete tonight's session, there will be another kind of recording for this part 3 as well. Thank you for Lisa for putting together these QR codes so that people can have access to the recording for these talks and for perpetuity. I'd like to start, our cases tonight with that first kind of advanced symptom that often we see in late stage Huntington's disease. And so this case will focus on caregiver strain. Lisa or Mara, would either of you read the case out loud for us?
Yeah, I can take this one. May has been falling frequently recently, at least once a week. She often uses her walker, though sometimes she will forget it. The front porch and bathroom have been the most common areas where her falls are occurring. May needs to meet blah blah blah. Sorry, May needs help getting back up. And once in a while, she has been alone and needed to wait an hour for her daughter, Christy, to come home. Christy lives 10 minutes away by car. She works full-time in an office. Christy is deeply worried about May getting hurt. Christy finds herself driving over even several times in a night. Christy is starting to feel frustrated with May's difficulty with remembering to use her walker. Christy is having trouble sleeping at night as well.
Thank you.
So thanks, Jocelyn. Anyone in the audience have any sort of thoughts or relate to this in any way, or can identify some of the things that might be going on? It's okay. It's the first one. Jocelyn can move it forward.
Yeah, so we can kind of open up and start talking about how would we approach this from a palliative care viewpoint? How would we address not only, of course, May's, increasing changes to her balance and her falls, but also Christy's worry and the amount of time and, energy that she's worrying about May. So, of course, I framed the case so that we could focus on one particular thing, and that is the needs of caregivers. As much as this experience is, of course, distressing and probably, worrisome for me, it really is affecting Christy as well. And we know that people living with, a serious illness, that often the people who are caring for them, supporting them through it, really develop intense needs of their own, especially in neurodegenerative diseases like Huntington's disease, where people can really develop progressive changes to their abilities, to their communication, and develop lots of different symptoms. We know that caregivers are at really high risk of burnout and strain. So if I were meeting Christy in May in clinic, I really would, at this point, direct my attention to Christy and really talk to her about, how her life is going, how she's able to balance working full time and also caring for someone who does need a lot of help. And I would ask her about her sleep and ask her about, the things that she is able to do for fun or to nourish herself. Mara and Lisa, I know these are conversations that you have all the time. I'm wondering, what are the kinds of your top few questions that you like to ask caregivers to make sure their needs are being met?
Um, I just was having this conversation today, so I certainly can go with this. The person that I was speaking with today actually has this additional sort of burden in that she has two children also with Huntington's disease. So she's very, very overwhelmed and has so much on her plate and just continues to put herself last all the time. She puts everybody else ahead of their needs ahead of hers. She actually has some serious health issues of her own that she's attending to, but not, I liked your word, nurturing, I guess is the right word you were using. So I ask things, like around the same kinds of things, what are you doing in terms of getting support for yourself? Are you able to go find any time alone? Is there a way for your person to be safe, for you to not be with them? Whether it be a family member or a friend or somebody that can come hang out for a little bit. Even basic things like doing the grocery shopping by themselves. can be very much of a relief, and provide what people need. I do find, I have to say, I don't know if you guys find this too, that people just kind of downplay their needs a lot. Um, the and then every once in a while I do get people who are articulate and can say, I really am burned out. I really need to do something. But for the longer time, it's no, I'm fine. I'm fine. I love them. I'm going to do what I can do to help them. So sorry, that was a long answer.
No, but I think that's true. I think it's easy for us to sort of minimize sometimes and to want to take on that burden for ourselves because we love the person so dearly and we, maybe committed to helping them and supporting them. And we forget to realize that there are people out there that want to be supportive of us as well. And simple little things, and I'm going to pick on Jody because I know she's not going to care that I say this, but we are in a caregiver support group, and she had a friend that offered to do like a meal train, I think it was Jody, and Jody was like, I don't know, I don't want to burden people. And, of course, every single caregiver was like, do it, like, don't, take advantage of this. And so Jody did it. And she said it was sort of, well, she can speak for herself because she's here, but it was a really good experience. And since she shared earlier that she's been getting additional help. So it definitely is helpful to ask for help. People want to help. Sometimes they don't know how to help, but if you can give them concrete things to do, it can help ease some of the caregiving needs.
And I'll just add to that. I feel like a lot of people, they really care and they want to help, but they don't know how to help. And in that scenario, that was, a friend of mine that I think she was in just that situation of, okay, I know food, I can do food, so this is something we could really help. And I sense I'm not doing that at this point, but at the time there was just a lot of stuff going in my life right now with my house, and I'm not going to get into it. Lisa knows all about it, but I just feel like everything was just falling in. And that's when John started becoming incontinent, and I was just, I just felt like I was kind of drowning. Like, I don't know what I'm doing. And I was so tired, and we weren't sleeping well at night. He was like, he would get up like every hour, and when you don't get sleep, you can't function. And so I just had all these things going on. I was just overwhelmed. And so it was just nice that I just saw as, okay, that's time that I don't have to spend in the kitchen, and that's time I can spend focusing on my husband or whatever. And so, yeah, I'm starting to learn more to, when people offer to help, like, okay, maybe that wasn't how I was thinking of help that I needed, but let me think about it. Like, every little thing can. So yes, I'm getting better about getting more help for sure. And it makes a huge difference.
I always remind people too, like, how do you feel when you get to help somebody else?
Mm-hmm.
And they usually go, I feel good. And I'm
Right.
like, well, think of it as giving your friends and your family a gift of giving.
Right. Yep, for sure.
And often, because I do work with so many different kinds of families and friends and extended family and chosen families out there, I hear from so many people similarly that, when someone is living with a difficult illness, part of the difficult part of watching them is feeling helpless, right? Or feeling kind of left out and feeling like there's nothing that you have control over in terms of what happens to your loved ones or even what happens to you in life. And so, really materializing that with small to-dos, but really concrete things really, helps everyone feel like they're contributing and connecting with one another in a meaningful way. Beyond, of course, a very thorough caregiver assessment and addressing those needs, some common things that I tend to suggest that can be really helpful with caregiver strain is to kind of reframe some of the resources that they've probably already heard about. One of them being physical therapy and occupational therapy. A lot of people living with neurological diseases and Huntington's disease get sent to PT and OT or even speech therapy earlier on in their condition, and they go to the office, they go to the clinic, they do exercises, and then they have an expectation that basically PT and OT and speech therapy is like that. But the home-based versions of these services actually kind of have a different framing and a different goal. Their goal is to come to the actual home to assess for safety, to really support caregivers and family members, and to help teach them about ways to navigate an environment if someone has changing abilities. So these home-based teams can really provide invaluable support. Say, you notice your loved one is really having trouble kind of getting up from a deep chair, right? You want a physical therapist to work with you in that specific chair to teach you as a caregiver how to help people transfer safely without injuring yourself. So there can be a lot of merit to kind of bringing these familiar resources out of that, environment outside into your home environment. One other big thing that we've already, started touching on is I talk with caregivers, what are the pros and cons about bringing in outside caregiving? And of course, I'm just going to normalize it and say the biggest con of all is the out-of-pocket cost for most people. Understandably, if you are connected to in-home support services, and home support services in California can provide a little bit of caregiving in the home, but often for people, they are having to think about hiring outside caregiving to some extent. So, I often talk with caregivers and just try to make it a normal thing, because it can feel intimidating to think about starting that process. It can feel a little intimidating to invite a stranger into your home. So for all of those reasons, this is a process, this is a conversation that takes time. And so I see as part of my role, just walking people along that path and just making suggestions about other things that other families have found helpful. Certainly, we can discuss transitioning to a facility. As we were talking about before, there are day programs out there that can offer a little bit of time-limited support. There are respite programs in different facilities for a short number of days. If, for example, the primary care partner in a family needed to go to a doctor's office or go get, a minor operation, or even just leave for a weekend, so that, the person living with Huntington's disease can still have supervision and still have help during that time. And certainly, I talk with people, through the pros and cons of even a more permanent transition in terms of home environment, when it turns out that the care needs are so high that it's not necessarily safe nor realistic in order for people to stay in the home. And all of this occurs, of course, this is the theme we've returned to again and again, within the context of the shared goals from both the person living with Huntington's disease as well as their family. If people have, a huge goal to stay in the home, certainly, as, a palliative care team, we will try to support them in whatever way to think about all the different options that are feasible. If their goal is, to maintain their relationship so that it's not colored as much by the acts and the demands of caregiving, right? That might be a little bit of a different conversation. So it definitely can shift and is very different from family to family, depending on their goals and obviously depending on their resources.
And I will just add here, I know we've been on it for a long time, probably over time, but for those that, need, let me back up. Susan and Michelle wrote that they worry about things happening while I'm gone. I'm guessing this is caregiver gone and HD person at home. And that is very scary. There are ways to set up your home. They call it smart home, where you have cameras, motion detectors, automatic lights, things of that nature. So the best place to find those things is aarpcaregiving.com, I believe. No, I do not get any kickbacks from AARP, but they have just a great website that talks about finances. What kind of questions do you ask if you're hiring someone to come in? If you are a caregiver, what kind of questions do you ask the PT or the OT person to help make the home safer, both for your loved one and for yourself, or make moving them safer and things of that nature. And in there, they have smart devices that are either wearable or videos or different things so that you can, maybe go to the grocery store for 20 minutes and not feel worried that your loved one is, crying out for help and, when no one can hear them. So aarpcaregiving.com.
That's a fantastic suggestion. Thank you, Lisa. So we will move on to the second case, and I'll read it. This will be about changes in communication. Casey's speech has been changing slowly for many years. Much of Casey's speech is slurred, although his brother John is still able to understand Casey half of the time. What bothers John more is the fact that Casey does not speak as much anymore. Casey used to be very chatty. Now Casey only speaks to John when he asks him a direct question. So John wonders if Casey feels lonely and feels discouraged by their slurred speech. And John wonders if he should be helping Casey socialize more. So this is just, one particular kind of example of how communication can change, but I think it kind of speaks to the multifactorial ways in which speech can change in Huntington's disease. So here, there's some of that slurred speech that can be very common when in Huntington's disease. But even beyond the slurred speech, right? John is really noticing that Casey just isn't as engaging in terms of using verbal communication in trying to speak to him. And that makes, John understandably worried and wondering, why is that? Is there something I should be looking for? Is there something I should be fixing? Does Casey feel lonely? And these are really, really common questions that I run into in clinic. So when we think about the palliative care approach to addressing changes in communication, sorry, not Janice's changes, but Casey's change. Well, first and foremost, of course, as all of you might be familiar with, slurred speech can be a type of neurological symptom that speech therapists can be very helpful with. So speech therapy doesn't typically reverse slurred speech once it's arisen, but certainly because the tongue it has a muscle, and because you can still train muscle, speech therapists can be really effective in helping people figure out what is the best way to communicate. What are the consonants that I have the most trouble with? What phrases might be really difficult to say, and what can I shorten to make my needs known? Also, in this case, we're really, just also noticing that there's been a change in maybe Casey's personality or the way that he engages with people. So it's really, really common in neurological diseases, including Huntington's disease, for patients to develop what their family really feels like is maybe depression. But then when you ask more questions and you really screen for depression, it turns out the person isn't necessarily depressed or having a mood disorder, but they just have less interests. They have less motivation, and that is something called apathy. It's kind of important to distinguish between depression and apathy because, while we have good medications that can really help with low mood and depression, there aren't that many good medications to actually target apathy. And so before people start going on a rigmarole, trying different medications to treat depression, often, just making it clear whether a patient is experiencing depression or apathy can be pretty important. And often with caregivers, I'm just working to name apathy as a really, really common symptom in neurological disease, and try to think of ways to help keep that person kind of on a routine, on a schedule, to make sure that they can still remain engaged with day-to-day activities. Speech therapists can also subspecialize in something called alternative and augmentative communication, which one example of this is in this picture on your right, which is an iPad or tablet-like device that can do text-to-speech, or basically express a need or a desire just by having someone point to a particular button. This is just one of many, 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 many different examples in the ways that technology can help augment people's ability to communicate, so that we can get around sometimes the frustration that people can experience when they have slurred speech and they just need to say something pretty simple, like I need to go to the bathroom, or can you hand me a Kleenex? So for those kinds of situations, these AAC referrals and speech therapy can be very useful. One thing I often talk about with caregivers as well is that even when people really do stop engaging with verbal communication, so stop using words in the way that they used to, I try to really name out loud all the other ways in which we already communicate with one another, whether that's through, our eye contact, whether that's through just our body language, our facial expressions, how quickly people are breathing. There's so many people that I've taken care of as a palliative care specialist, people who've been very sick, and their family members have, really asked me, how am I supposed to know if they're suffering? Or how am I supposed to know if they're in pain? And what I can say is, even if someone is not able to communicate that in the way that they used to, there are other kinds of bodily signs that we can use to interpret how someone might be feeling. So I want to, and those, are really standardized and have been validated even in studies looking at the effectiveness of medications for certain symptoms. So I want to reassure family members that it's still possible for us to be able to make sure that someone is comfortable. Along that, often I'm working with people, family members, to identify other ways of connecting with their loved one. I often use this kind of example where I say, while in your old life, many years ago, you maybe faced each other and you had a discourse where you kind of looked at each other. Sometimes when people develop more cognitive impairment, or they just can't have that back and forth, that repartee, that conversation, instead, can you face out at something together instead of facing at each other? Because when you're facing out together at something else, you might be taking in music, you might be taking in the sun, being outdoors, you might be holding each other's hands as you do it. Those are other really, powerful and sacred ways of connecting with people and letting them know that they're cared for and they're known and they're loved. So go ahead, Lisa.
I was just going to add to when the HD person has more difficulty speaking, they likely also have more difficulty processing information. So identifying sort of what time of day is best for them. Sometimes it's morning, sometimes it's evening, sometimes it's midday. And you'll kind of know that because you'll know when you talk to them and then they don't remember, and then it makes you frustrated because you're a human being and that just happens. So you'll kind of start to see that pattern. The other thing is to make sure that there is eye contact before you have that conversation. So I don't know about you, but I do a lot of yelling through walls or upstairs or different places to get my family's attention. And, most of the time, let's be real, they don't listen to me. And it's because they might have even said, yeah, mom, but then they didn't really process and they weren't really ready to engage with me and to hear what it is that I had to say. So the best way to do it is to make sure that you are facing each other, you have eye contact, so that your loved one can also read your nonverbal communication to try to better process that information. And then the last thing, especially with the holidays coming up, it can be very hard because some of your maybe traditional family traditions and things can't happen because it's too hard. They can't leave the house the same way. They maybe neither one of you like to be around people as much, or you just need sort of more quiet, small group activities. Just remember that while you can't do the same things for the holidays, you can continue to make memories, like Jocelyn was mentioning, holding hands. Sometimes it's, some of our families have done like a pajama night and they do watch a movie that, everyone probably knows already, but everyone can sit and enjoy that. And that's what they do on, whatever holiday. Or or going for a walk, or, different things, that sort of new family traditions that you can do to sort of minimize any, stress or anxiety for both of you, the HD person and the loved ones, because let's be real, the holidays are stressful for everybody.
Such good tips, such good advice. Thank you, Lisa. Moving on to case 3. So I can read this one as well. This one will focus on alternative feeding methods. Carla has had swallowing changes over the past 3 years. She underwent extra testing at the doctor's office with speech therapy. So the test they did was a modified barium swallow test. And that showed that a lot of thin liquids were going down into her lungs instead of her stomach. She's lost 5 pounds over the past month. She doesn't want a feeding tube, though her husband Tom wonders if she should consider getting one placed. I'd be curious if any of you, anyone joining this talk, or anyone who might be watching the recording is thinking about this issue and how it's impacted them and their family. It's a really, really common and a big topic for many people living with Huntington's disease, which is why we talked a little bit about it in the prior part 2, and now we're going to also expand on it a little bit more today.
I can just share real quick from my perspective. That's something that many years ago, my husband and I discussed before he was really impacted by the disease, and he has no interest in a feeding tube. He doesn't want to prolong the inevitable, and when you really don't have much quality of life anyway. So for me, I'm thankful we had that conversation, because I can only imagine when we get to that point, and we will get to that point. He already does have some issues a little bit when he's drinking fluids, but although it still won't be an easy thing, but to know that, okay, I know what he wants. And so then there's no, I don't have to worry about it or wonder if I'm making the right decision. I'll be doing what I know that he wanted.
You'll be honoring his wishes, and that's what we all want
Yep.
sort of at the end of life, is
Right.
to feel like we're heard, and our wishes are honored, and of course no one wants, that's a really hard decision to make for somebody. So if you know that their decision, in the event they would have been able to make it for themselves, is this, it makes it a lot easier, and you can, be comforted by the fact that you're honoring their wishes. So I think that's great. Thanks, Jody, for mentioning that.
Yeah, and I'll just say just really briefly that also just where we're at right now, like with his dementia and his cognition, like I can imagine to have that conversation at this point, like he just isn't understanding what's going on. So, right. So now I know I don't have to have that discussion. It was made when he was in the right frame of mind, and yeah.
Yeah, when he was able to process the information, that was big.
Right, for sure.
That's something that I don't want as a feeding tube, and I've made it real clear to all of my family, while I could, and that was, that not only do I not want a feeding tube, I've got a DNR, because I don't want to prolong anything.
Thank you to Alice for sharing that. I want you to hold that thought about maybe some other wishes that you've discussed as well, because that will come up in our next case. But I think the fact that, the two of you have, that these have been really, really intimate conversations that you've already had really just shows how common of a symptom and an issue it is for people all over the country living with Huntington's disease. When we think about, these following issues, especially in late stage Huntington's disease, of course, as a doctor, I'm mainly, there to learn from the speech therapists. So I really work closely and collaborate with speech therapists, because I really try to incorporate all of their advice into my advice for people when it comes to thinking about safety and swallowing. On the right here, you can see a couple pyramids that the speech therapist, the speech and language pathologists often use. They will often say after a meeting with someone and evaluating some swallowing issues that they might recommend some modification of textures for solids and liquids. Often when a neurological disease affects our swallowing, we might have more difficulty with larger pieces of solids or thicker ones. And that's why, over time, your speech and swallow therapist might recommend cutting the food to smaller pieces, making sure it's moist, and then even pureeing it. And for liquids, typically for people with neurological causes of swallowing difficulties, people have more trouble with thin liquids, so things as simple as water. And when you tend to thicken the liquids, they can actually become easier to swallow. So I always say to people, first see a speech therapist, because they will take you through these pyramids and figure out what kind of mix and texture works for you. Along with that, the speech and swallow therapist can really teach people some really kind of low-hanging fruit for precautions against aspiration. Aspiration is kind of what was discussed in the case in which someone's food and liquid is going down into their lungs instead of their stomach. So the precautions that speech and swallow therapists often can suggest can be very effective. They can be as simple as minimize distractions when eating, make sure you're sitting straight up and you're not lying flat. So they can really take you through some practical steps to minimize any major complications from these swallowing issues. These next two things are things that kind of target that part of the case, which talks about weight loss. Often when people might, have lost some appetite or might be trying to regain some weight. Some of my patients feel like, oh, I'm still trying to balance all that advice I got from my doctors 30 years ago, which is don't eat any salt and don't eat any fat and don't eat any candy. And what I like to tell people is if you have a neurodegenerative disease that is, likely causing some weight loss, I want to encourage you to eat whatever brings you joy. If that happens to be broccoli and celery and all those good, things that are, on the vegetables, do that, but also allow yourself snacks. Treat yourself, allow yourself to enjoy whatever you would like to enjoy in your diet. And if you are feeling hungry between meals, allow yourself to have some snacks. And then, as we were talking about a lot before, I talk with a lot of families about feeding tubes. Some people, can come to a decision and often do way before these swallowing issues emerge and decide for themselves that no, it's not for me. It's not something I'm interested in. Some people might say similarly, and then as time goes on, they might change their mind, right? That's also very common. And then some people tell me from the get-go when I first meet them, I mean, like they're definitely open to thinking about this kind of intervention. So I really work with people across the spectrum. What I do tend to kind of bring to the conversation is the fact that no matter someone's preference regarding the feeding tube, my job is to support them through that decision-making process and make sure that their care plan really reflects what's important to them as people, and I try to align the kinds of interventions based on what's possible medically. So I will talk with people who are interested in a feeding tube about what's involved and certainly the amount of care that they require. But I also talk with them and discuss, are there any situations in which you would want your family to stop using the feeding tube? What would you like done with the feeding tube when it becomes readily apparent that you are reaching the end of life and you've entered the dying process? And I try to give that framework so that people have an understanding of the potential questions that they might be asked by doctors later on, so that they feel they are prepared to have those conversations.
I was just going to add one thing to that.
Yeah.
Oftentimes in clinic, we will talk a lot about pick your battles or pick which hill you want to climb with your loved one. And food is a big one that often comes up. And, as parents or caregivers, we're always like, you got to be as healthy as possible, kind of like what Jocelyn was saying. But I will tell you an extreme example where I had a patient, he was rather young in his 40s. And for about the last 5 years of his life, he would only eat Little Caesars pizza. I think it was a milkshake from Wendy's or whatever their milkshakes are called. And then his mom made some candy that he would eat, and he would eat, uh, you know, crock pots full of this candy every week, or, like every 4 days.
Wow.
Now, was it a healthy diet? Absolutely not. Was he happy because he would take the whole day to eat a pizza? It would come home hot. He would eat the hot pizza, in the morning for breakfast, and then cold pizza at night, and he didn't care, and that was just what he liked. And then he would sip on the milkshakes and eat the chocolate when he wanted to. And, the mom, of course, was like, he needs to be eating healthier stuff. And, she was trying to do all these things, and she was really stressed out about it. And I said, what if we just let him eat whatever he wants to? Because, HD has taken so much away from him. Let's let him, eat these. And she started letting him eat them, and they had started having, better relationship. She could just enjoy his company, and he didn't have to fight with his mom about what he was going to eat that day. And they just knew that this was his diet. And honestly, he survived many, many years on that diet. But again, we have to think about what is the end goal. And, yes, for some of us that maybe don't have some of the medical issues, we cannot eat like that every single day. That is very unhealthy and will cause medical issues for us. So you just really have to pick your battles and your hills with your loved ones. And, honestly, I will say it here and now, if chocolate is the thing that takes my life, please let it be chocolate that takes my life. Like, do not withhold chocolate from me at the end. I will be very upset. So anyways, you just don't, everything in moderation. If excess is kind of the way they're going to go, sometimes that's okay too. You just have to sort of talk with your care team about what's going on so that we can best support you in your journey.
I love the expression, everything in moderation, including moderation.
Right. Yes.
Yeah, I love how you highlighted there, Lisa, that, for many people who feel like a serious illness like Huntington's disease, it has robbed them of a lot of different choices, right? And a lot of different potential futures that they otherwise would have been curious about. Sometimes the simple pleasure of being able to make some choices in the now, in the present for your day-to-day life carry extra meaning. And so sometimes that's how I frame it to families as well, when there's, just wars being fought over the dinner table. That's probably one of the things that's going on underneath all of that. Moving on to our last case today. So, Mara, would you read this case for us?
Sure. Janice has lived with her diagnosis of Huntington's disease for a couple of decades. Her children, especially her son Michael, are very close with her. Janice has been living in a nursing home for the past year. Michael has noticed that she's been getting weaker and spending more time in bed. Janice has always told Michael that she didn't want anything heroic at the end of life, and he wonders what that really means.
Yeah, definitely a vague phrase that we can definitely think about and talk about. So often people, ask me when things are clearly changing and shifting, how do we cope with that? How do we kind of think about what to do when we see the disease progressing in front of our eyes? So as you can imagine, this will be many different things that people can think about. These are just a few of the priorities that I tend to try to take on in palliative care clinic. First and foremost, I try to really connect care partners and caregivers to support. Huntington's disease, like other neurological diseases, can be a very long and uncertain path for many people. So providing them that kind of emotional, psychological, and spiritual support is really key. And that's even more important as time is growing shorter. for many people, we were just talking about chocolate. It can be as practical as identifying sources of joy and meaning. So often I will ask families when I first meet them, what have you noticed brings this person joy? And I have to say, sometimes it takes a little bit of thinking, right? Because maybe someone's lived in a nursing home for a while and their family doesn't see them as often anymore, or maybe there's a lot of things that that person can't do that they used to enjoy doing, like maybe fly fishing and skydiving and all sorts of things that they are no longer able to do or access as easily. But I try to my best to hear, is there anything that, you've noticed that this person, that brings them light or brings some novelty to them or helps them emerge and seem engaged. And then we kind of go from there to see what are the things that we can really do on a practical basis to bring out more of that for that person so that their quality of life can be as good as it can be for as long as it can be. And this last piece, these last two, I think will help us kind of transition into this next topic. A big part of what I do in my clinic is helping people and their families plan for the future. So with Janice's case, she clearly had some tough conversations with Michael in the past and said she didn't want anything heroic done. Maybe Michael's, a couple decades older now and wondering, well, what does that actually mean for my mom? And I would never expect a family member to just be able to inherently know what that possibly can mean. Often in medicine, we can debate what it means to do what the possibility of different interventions might be in terms of how helpful they might be. So often, I want people to understand that you can partner with your providers to get a sense of what they consider to be interventions that make sense in the context of your goals and what's achievable feasibly and reasonably by the medical system. You can partner with your palliative care team to get a sense of, well, how do I plan for the future that I most want? What are the decisions that I have to make along the way to make those things possible? And as a part of this, especially as disease progresses, one of the big focuses of my clinic is helping people prioritize what's most important as time grows shorter. So here I'd like to just talk about the transition from palliative care to hospice. If you've been with us since part one, you've seen, an introduction to palliative care. You've seen us talk about how palliative care can be helpful in supporting people living with symptoms related to Huntington's disease across different stages of Huntington's disease. And now is the point in time when I want to start to talk about when I typically start thinking about transitioning one of my patients from receiving palliative care to potentially receiving hospice care. So these are some very general things that I tend to look for that might tell me that time might be growing shorter. So your team may discuss hospice with you when you or your loved one notice that your loved one with Huntington's disease has been losing swallowing function, has been losing their appetite, has been experiencing weight loss, or has been really experiencing other nutritional issues. So they might have been told by their primary care doctor that they're not only, have they lost weight, but they've also lost a lot of muscle mass. They've lost a lot of strength, and they might be much weaker and more frail than they used to be. You might also, be discussing hospice when it becomes obvious that there are just a much higher burden of symptoms, and maybe the medications that your neurology team, your Huntington's team had been prescribing for many years just aren't really cutting it anymore, that they're not quite as effective as they used to be. And so these symptoms might be really requiring more support, more care at home. Often I'm also looking for recurrent infections. So often my patients will say, it's like we're playing whack-a-mole. One day, My husband has a urinary tract infection and that gets treated. And then just a few weeks later, he has a pneumonia and then we have to go back to the hospital. And then a couple months later, he has difficulty swallowing and that led to an aspiration pneumonia, and all these kinds of infections are kind of like whack-a-mole. You whack one down and another seems to appear and rear its head. And this is also, sometimes a sign to me that as a palliative care specialist that we might want to think about hospice. Similarly, along that, recurrent hospitalizations, especially if those hospitalizations are related to frequent falls, that just tells me that this person is growing weaker. They really do need more support. And also falls are usually a sign that, the disease is continuing to take its toll. As a final reminder, I want to say palliative care, of course, is based on the needs of the patient and not on the prognosis. It is appropriate at any age and at any point in a serious illness. And that's what makes it different from hospice. So very commonly, one of the first questions that people ask me when they first meet me in clinic is this, referral to talk about hospice? Palliative care and hospice are not synonymous, so I will advise you that many well-meaning and well-educated healthcare providers will conflate these two terms. So I'm very glad that you are all here to help us get this correct. As we've described, palliative care is a large and broad field, and we are here for patients of any age and any stage and can be involved in addition to curative treatment. Hospice, again, is a small part of that type of care that palliative care providers are trained in, and it is only a part of what we provide as a field. Hospice care can be a little confusing because the term really refers to several things. Hospice is often used to describe a philosophy of care. It's also an insurance benefit that is included in all insurances, and hospice is a set of services that can be provided in any setting. That means the home, a facility, or a hospital. As a philosophy of care, hospice focuses on supporting patients for whom comfort and quality of life is the highest priority. Hospice typically thinks about every intervention, lab test, medicine, and asks the question, does this help the person feel more comfortable? If it does, hospice will try to do that thing and make it happen. If it does not, hospice might recommend stopping that test, medicine, or intervention. Again, the philosophy of hospice is a really good fit for patients who want quality of life and comfort to be their number one priority, because that often does mean that people are less focused on pursuing interventions that might prolong life and might prolong the dying process. As a philosophy, hospice also aims to support people being in the place that's most comfortable for them. For many people, that happens to be the home. So hospice does everything they can to make people as comfortable as possible while keeping them in their home. And typically they work to avoid going to the hospital. For some people, being the home is not what's desired or not necessarily realistic. So hospice services can be provided, often is provided in nursing homes and even in some specialized hospice facilities. As an insurance benefit, hospice services are covered under every insurance plan. Those, as usual, there are regulations and guidelines that hospices must follow. Medicare provides the guideline that patients should have a 6-month or less estimated prognosis to be eligible to receive hospice benefits. The philosophy of hospice is to provide comfort-focused care. Therefore, again, hospice may or may not pay for certain treatments that do not provide more comfort. Although, and this is something that I feel like I run into every day, there's more and more variability in what certain agencies will cover and allow under their care. So talking with hospice agencies specifically about your loved one's individual case is always helpful, as unique situations happen frequently and everyone's circumstances are different. Hospice through an insurance benefit is typically delivered by a hospice agency, and some of the local Bay Area ones or even national ones would include Mission Hospice, Pathways, and Vitas. Hospices like palliative care teams are composed of an interdisciplinary team that includes the doctor, the nurse case manager, social worker, chaplain, volunteer, and home health aide. As I mentioned before, hospice is not a place. This service can be delivered in the home, in nursing homes, and in some specialized hospice houses. Another enormous benefit of hospice is that it provides you access to a 24-hour nurse phone line. This is staffed all holidays, all weekends, all nights. And when called, the nurse can help give you advice on how to manage symptoms with the medication that you might have at home. If your needs are more than what can be done over the home, agencies have the ability to send a nurse out to see patients when needed, often that very same day. I think it's also important for people to know that hospice has the ability to follow you to a facility if you do need more care. A not completely uncommon scenario is that someone might start receiving hospice at home, and over time their care needs can increase, and then they might feel more comfortable in a setting where there's nursing staff around 24 hours a day. And hospice can help facilitate that transfer and continue to follow people through that course. Hospice also takes responsibility for prescribing all medications, providing medical equipment like a hospital bed, a bedside commode, and a wheelchair. And one important caveat to note is that hospice is not able to provide 24-hour care for personal needs, such as getting up to use the restroom or bathing. So family, friends, or other caregivers or other facility staff are needed to provide that at home or in a facility. It is really, really normal to have a lot of questions when you consider hospice or when your providers mention hospice to you. Here are just a few of them. How can the hospice team help me? What do I do with all my Huntington's medications? How long will this last? And most of all, what will the end of life for my loved one look like? I'll address a few of these right now. How the hospice team can help you. Certainly your provider can go through that long list of services that hospice provides with you and see, are those services going to add anything to what you already have going on, whether that's at home or in a facility. And in terms of your Huntington's medications, often continuity of care can be arranged with your Huntington's disease team in the sense that the hospice, you can ask your hospice agency to touch base with your neurologist and your Huntington's disease team to make sure that there's a warm handoff, that they talk about you or your loved one, and they know from the specialist themselves, what the specialist might recommend in terms of your medications. Because all these symptoms are meant to help with quality of life and symptoms, usually most of your Huntington's symptomatic medications should be continued. In terms of, how long will this last? That is a really, really important question that I hope you all feel empowered to ask any provider when it appears in your mind, as hard as it might be to say those words, because we all know that timing affects the way that we make decisions and the way that we think of our lives in the world. So that information, if it would be helpful for you, I just want to say it's entirely normal to ask this question. What I can say as a neurologist is that we know there's a lot of uncertainty in prognosis, especially in neurological diseases, and especially in Huntington's disease. And so I'll kind of point you back to that short list that I had on the slide when thinking about transitioning from palliative care to hospice. There are some hints that we can put together, some clinical thresholds that can tell us, someone's prognosis might be shortening, and that time might be looking like a certain amount of time or a range of time. And as a family member, if that information would be helpful for you when you're making this decision, then again, this is information that you have every right to know if it's going to be helpful for you. I also want to say out loud that hospice criteria was developed in the 70s and the 80s. And back then, it was developed as primarily a way for people living with cancer to receive benefits. And so a lot of the other kinds of conditions like Huntington's disease, Parkinson's disease, Alzheimer's disease, the hospice criteria that helps doctors determine if someone can receive hospice may not be perfect. And this is an area of continued research and development, and hopefully will change over time. But I just want to say, if you start to feel frustrated, feeling like your loved one, of course, would benefit from hospice, but still doesn't meet the seemingly arbitrary criteria that people might be talking to you about for hospice, that however you feel is completely justified. And is a really, really common problem that hopefully we will have a solution for sometime soon. I always like to emphasize whenever I talk about hospice, because it's a really common question. Enrolling in hospice doesn't mean you're giving up on your loved one. Doesn't mean that there's anything being said about how much you want to care for them and how much you're devoted to them. In fact, hospice is meant to be a source of support for the individual and their family during this really, really special and precious time of life. Often people will say to me, it might feel like I am giving up on my loved one. And what I hear when they're saying that is that there's a deep amount of grief and sorrow that that person is going through, as even anticipation of the end of life. And I just tell people that it's normal to feel that way. When it comes to thinking about the end of life and what it might look like, feel like, sound like, even smell like, that's where I will leave us today. As I hope that will be covered. I'm sure it will be covered in a lot of detail in our part 4, which I'm really, really excited for. Per usual, I have a resources slide, just in case people wanted these links that I've been presenting at every talk to find a palliative care program near you, no matter where you are in the country. The link at the bottom, getpalliativecare.org. You can put in your zip code and find a palliative care program near you that can walk with you and your family as you face this road together. Thank you all for all of your kind attention this evening, and I'd love to open up for discussion and questions.
Yeah, I'm really curious if people here, maybe not with their loved one with HD, but for other family members, have had experience with hospice care.
And my brother had hospice for over a year at my house.
Yeah, we hear that too, that people will kind of go in and out of hospice, I just got dropped by hospice, or those kinds of things happen and then they get put back on hospice. Did you find it to be really helpful, Alice?
Yeah, I couldn't have, without having somebody come in and bathe him, 3 times a week, and without hospice coming in.
Mm-hmm.
I mean, they sent, like you said, there was a pastor, there was somebody that, did all his vitals and medication and took over ordering all the insure and thickener and stuff that he needed.
Like Jocelyn said, it's really meant to be supportive for not just the patient, but for the family as well. And as someone who's lost both of her parents and been through hospice both times, I can just speak to the fact that it really allowed me personally to grieve and feel what I needed to feel rather than being obsessed with the details of things. Of course, we were obsessed with, what do we do with this situation? That kind of thing. But hospice always answered the phone. Hospice was always there with a suggestion. And it was very soothing to, or really racked nervous systems, at that time.
Yeah, and I think, I've approached the conversation with many a patients, and it's always hard because I don't ever want to say, have you thought about hospice? If, because let's be real, once people hear that word, they think, oh my gosh, you think my loved one is dying tomorrow. That's not what we think when we mention hospice, PS. But that's kind of, what people start thinking. And again, it goes back to, what Jocelyn was saying, that if there's an increase in challenges with caring for the loved one, or how recurrent infections or frequent falls, or just it appears that the quality of life, both for the person living with Huntington's and the caregivers, is maybe getting more difficult to manage. That person, maybe the meds don't seem to be working as well. They seem to be a little bit more uncomfortable or restless, or maybe even in pain. Those are the things that hospice are really good at, keeping people comfortable and peaceful. And they have the boots on the ground, if you will, where they can go into your home. And unfortunately, Mara, myself, and Jocelyn cannot go into your home. So, it can be a very helpful resource. Hospice is something that you should consider earlier rather than later. I would highly talk to you about just sort of trying to feel like you can openly talk to your team about end of life and those stages, and what you need to do for plan for that, and what your goals of care are, so that we can help sort of initiate that transition when it's ready to do it. A major thing that, at least recently, we've referred a couple of people to hospice recently, and believe me, it breaks my heart every time I have to say it. But in both of the cases, the person with Huntington's was experiencing symptoms that were really distressing to them, to the point where we were on the phone with them, every few days, trying to adjust medications and things, and nothing was working. Which also indicates to me that there's something going on that we can't solve, and it's not just HD related. So we can get hospice in there to take a look at the situation, and they can get the things. Maybe it is just equipment that will help them feel better, or maybe it is pain medication, or other things that can help you just sort of ease some of that. And maybe it is having the nurse available 24/7, even though you might not use it, but that they're there. So there is some comfort in knowing, as with everything hospice, if you start it and they're not helpful, or it's not beneficial, or it's causing more problems for you, we don't have to continue it. Or we can find another agency that might, better serve your needs. That almost never happens, PS, but we can do that if it's needed. But just know that it's a service out there, and the earlier you set it up, the more supportive in nature it can be for you and your loved ones. And I think if you are already in palliative care or your neuro HD clinic, we stay with you until the end. We definitely don't, we will do the handoff. Hospice will manage the care, but we obviously provide insight and support, and the medication management, especially of the HD specific symptoms, so that we can make sure that those continue to be well cared for as well.
Yeah, thank you.
We're getting a question here, looks like.
Oh, let me take a quick look. I can read it.
Sure.
This from Susan and Michelle regarding preparing for challenges. We're admiring of how Jody has had conversations about life decisions while her husband is able. We are trying to go over these things, feeding tubes, hospice, etc. Wondering if there are other specific topics that we should address at this time while able. So I guess when I think about planning for the future, I think that a lot of what we talked about obviously is really important. That's why we put it in a presentation and put it in a web series for you. So I'm so glad that the material and these kinds of decision points that we've gone over have kind of spurred some reflection for the two of you, and for potentially people watching this recording. The other thing that I will just say, when it comes to other topics to address, when palliative care studies have tried to look at, can you create like a list, a comprehensive list of all the different decisions that you could possibly ever have to make when it comes to your medical care? Usually we come up with a list that is unconscionably long and complicated and convoluted and not realistic to use in any everyday purpose, which is just to say that there's almost no way that you can always predict, what's going to happen in the future and what decision you're going to be confronted with. While there are some really common things that you can anticipate in Huntington's disease, like the things we've talked about, I also like to make room for the fact that there are always going to be medical decisions, especially that take you by surprise. And I want to say that that's normal, and that's not a failure of not being prepared. That's not a failure of not thinking things through or doing your research. That's just because life is really mysterious and really, really complicated. So often my advice to anyone who might be like listening to this and wondering about other things they should think about, what I like to always tell people is no matter what that decision may be, we should be rooting it in what's valuable to you as a person. And maybe that's something you might do some soul searching or reflection about, but it's not something that you're going to look online at a resource and read about, right? It's really about you as an individual. What are the things that are most important for you to accomplish in this time that you have on this earth in this life? What are the things that have brought you joy, that give you meaning and satisfaction and hope? What are the experiences that maybe you've seen other people go through that inspire you, that you want to replicate, or things that you want to avoid? If there are any unacceptable ways of living out there, then what would those be? And often I like to tell people that if you have a clear sense of what those values might be, those hopes and those worries, then all you need to do is find the right team to help you kind of translate that into a medical plan. Because doctors and nurses and advanced practitioners, the medical system is geared up to present you with all the options that you might run into one day. And they can help you determine what makes the most sense in the context of what's important to you as an individual. But in order to come to that conversation, really knowledgeable, the thing that I really hope that people have a deep knowledge of is, who they are as people and what's most important to them moving forward in life. I know that's a little bit of a philosophical answer, but that's actually what I earnestly believe. So I don't know if Lisa and Mara have other things to add there.
I love that answer so much. I have to be honest that, it spoke to my soul. So I appreciate it. I can be a pragmatist too. So I kind of always, make sure I talk to people about, people often feel better when they get their affairs in order, that kind of stuff, the logistical things about wills, trusts, powers of attorney, just getting those kinds of things sorted can free you up for that more philosophical feeling and discussion, I think, too.
Yeah, I also thought it was a great answer. So did Susan and Michelle, but well, they said great answer. But yeah, I mean, I think just by asking the question, you're already a step ahead and doing the work, because you're gathering information. And as you're gathering information, it's probably triggering questions. Oh, I need to ask, Michelle this, or, oh, I need to ask Susan this, or, whatever it is. So, these are the types of things that you should be doing. We can only do what we can with the knowledge we have currently. None of us can predict the future. And, of course, as your understanding, knowledge, or things progress and change, maybe we'll get new knowledge, and then, so we have to refocus and re-ask some questions and things. but you know, Susan and Michelle, that's something that you can address with your team, i.e. I know who your team is. But you know, you can certainly address it. And we are happy to talk about those things. All teams are. And you know, I mean, if we had a crystal ball and could say, this is what you do and everything's going to be, you know, chocolate and roses and, you know, perfect, we would certainly do that for everybody. Unfortunately, that's not realistic. So we're all just doing the best we can. And I have conversations, you know, on the daily with people just like Mara and probably Jocelyn, where, you know, we talk about these things and we're like, is there anything we're missing? And what should we be thinking about? And those types of things. And so just staying in contact with your Huntington's team or your, you know, Huntington's Village or support groups or whatever it is so that you can, you know, identify these areas like, oh, we got that taken care of and that taken care of. Oh, but someone mentioned this and we didn't take care of that. And so, you know, maybe that's something we should consider. So honestly, I know you guys and you guys are a step ahead of everybody. So I think you're doing well.
If I could add my perspective a little bit of just some things that I've learned.
Please.
Sure.
So we actually did a bunch of updates to our home. And some of it was just my home needed to be updated, but really put some thought into, okay, my intentions is to keep my husband at his home as long as I possibly can. And so things like we built a master, I didn't have a master bathroom before, but thought about what should that look like? How should that work? You know, things like that have been super helpful. Like, and I do work from home. And it's a good thing I do because otherwise John couldn't be at home. So we're at home a lot. That's my point. And I'm really thankful that we did the things we did at home. So that would be one thought I would have when you're thinking about trying to think ahead. And the thing is, if you do those things well in advance, then when the time comes that you need those setups in your home or whatever, you're not having to stress about the moment and be like, oh my gosh, now this isn't working. Now what do we need to do about this? Like, then you already have those things done. So do those things well before you need those things. I wanted to mention I've learned about with the speech pathology that and like with the devices that were shared earlier, that they can also, like, if you do this earlier on, like they can record your voice before your voice starts changing. And I don't know, that's like to me, I don't know if that's a huge deal, but I think about that now because my husband's voice is completely different than what it used to be. And honestly, there's times it makes me kind of sad to be like, gosh, do I remember what his voice even sounded like before? Right? Like, it's just so much different now that that kind of would have been a nice thing had I known about that, you know, long time ago. But the thing is, you have to capture that well in advance before they start having those changes. Another thought from my perspective too is, you know what, also try not to overthink it and live life, take those trips. We did a lot of that. Like, so yes, throughout our married life, we've went on vacations and such, but once my husband quit working, I really kind of got serious about and really thinking about it, and he was still able to go travel. We did travel quite a bit. Actually took the Amtrak a lot because I didn't want to have to be driving. And so then I was really able to enjoy it. And now we're to the point that I just can't take him anymore. But I am so thankful I did that. I've actually even created, Christmas before last, I gave him a book. I created a book and I took all those photos from all those trips, and it's sitting on my table, and he'll get it out frequently and just flip through it and look at it. And so those are, I guess, some of the things that come to mind.
Thank you so much, Jody, for sharing all those. Those very sweet and very helpful.
Yeah.
And Susan and Michelle agree. Very helpful. Thank you, Jody. If you can't see their comments.
You're very welcome.
We learn so much from others that have kind of gone before us or, you know, or walking the same journey. So
yeah, and
it's
I will
really
just
valuable.
plug support groups. They are, you know, of course I'm biased because I do facilitate some of them, but anyways, they're a great source of support. One, so that you don't feel alone. Sometimes we feel like we're alone on this island and we must be the only caregiver that feels this way, or the only HD person that feels this way. And then you get into support group, you're like, oh, everyone feels this way, or oh, it really is that hard, and different things. And I will tell you, we have support groups for HD persons, we have support groups for caregivers, we have support group for everyone, you know, that joins together in the same group. Anyways, lots of helpful information, of supportive information. Every support group that I've ever been involved in, you know, the group members just, you know, love embracing new people and helping support them. And, you know, the goal is to make, you know, everyone after us to learn from the journeys before us. So, and they do that with, you know, grace and great wisdom, like Jody is sharing right now. So support groups are a really great way to get a lot of these questions answered, and to find your village of support. And then when you have a question, and if you can't get a hold of your social worker or your team or whatever, you can ask people that are actually, you know, walking in very similar situations. And honestly, that's where I can speak for myself, that I have learned almost all of what I know about HD has been from people living with it and people that are, you know, caring for someone with it.
I totally agree. Thank you everyone so much for not only attending, but also participating and sharing your thoughts, your wisdom, your questions. I know that this topic might hang a little heavy on your heart this evening, and I want to say that that is human. And I hope that you all have a lovely evening. And again, I'm really looking forward to part 4 in 2025. So thank you all again for your attention and have a lovely night.
Yes, and
Save
happy
the date.
Thanksgiving. I think it's a great week to be doing this because we can all see silver linings and find the joys and be grateful this week, or well, next week. But happy Thanksgiving, everyone, and please reach out
Happy
as needed
Thanksgiving.
to any of us.
Thank you.
Have a good evening.
Bye, everyone.
Bye-bye.
Bye.
Thank you. Bye-bye.
Bye.